Welcome to the Tryon Medical Partners webinar. Today's October 22nd, and it's good to have everybody with us today. I'm Patrick Brady from Tryon Direct, and if you've been on our last few webinars, you've known we're spending our time now on COVID-19 out of necessity. And as Dr. Owen, our CEO, mentioned last week, we may well be in the second wave, something that you've heard about for months. And as a quick refresher, for the last several weeks, as we've covered COVID-19, we've had a few main topics that we've talked with you about. So what's happening in Washington? Everybody's been interested in that. Why the 1 to 2 day turnaround on testing is so important, especially now, if we are now picking up with more and more testing and positive cases and hospitalizations and so on. We've talked about the vaccine trials. We've talked about the impact that flu and other fall illnesses are going to have. And now today's discussion is going to focus on a few key areas. What does the death rate look like? Something Dr. Owen gave us a precursor to last week. What is this antibody therapy that we heard about first with the president, and now you're seeing it more in headlines? The vaccine trials, as you see here on the agenda. And then finally, what are the appropriate guidelines for testing or not testing, whether you're talking about asymptomatics or symptomatics? And before we jump in, I want to try to get a little audience participation here, just to get everybody going. And if there is anything in particular that you want Dr. Owen to cover, would you put that in the chat now, or come off mute if you're on your phone, and let me take a quick glance at the chat window. We want to be sure to cover that. Maybe this will get us going with some thoughts, give Dr. Owen a little bit of additional direction. And if not, we'll do what we normally do, and that is just get things kicked off here. So I'm going to give it a pause for just a second. We're not going anywhere. All right. Okay, not seeing anything in the chat. We will continue here. As a reminder, if you are looking for ongoing information from us, then send us through our website, tryondirect.com. Any questions that you have, we monitor that. We will get back to you very quickly. The webinar gets posted to Tryon Direct tomorrow, October 23rd. And Dr. Owen, I do have one question. Oh, I got two questions. Fantastic. Let's start with those, and I'm going to turn it over to Dr. Owen, but let me prompt him with these two questions. The first question, Dr. Owen, actually got three questions. Are there new thoughts on how the virus is transmitted and what the primary risks are? New thoughts.
Sure. I think some of the newest thoughts is that it's not, and this will also answer question number 3, that it's not as primarily transmitted by contact of surfaces. We're seeing a lot more transmission from the standpoint of aerosolized droplets and so forth, but these are heavier droplets, and this is why it was on surfaces and so forth. It doesn't mean that it isn't transmitted by surfaces and touching and so forth. It is, but it's not nearly as significant as initially thought. And still the main way is cough, sneeze, talking with people, things of that nature. And, you know, some of these particles can, you know, run 20 to 30 feet out. That's why you've seen some of these studies of restaurants and how somebody, the target person who's sick may be 30 feet away that, or 20 feet away, that somebody else gets sick from it because of the way that air conditioning vents push things around in a room and so forth too. So indoors is a real problem. And it is increased by the fact that we tend to have various air circulating types of equipment going on that will move particles further around. And then when you're outside, it disperses it so much. Now we're going to be inside a whole lot more. And so we're going to see this occur a good bit more And this second wave that we're talking about, that will be one of the major variables there. Then what is the latest on therapeutics to treat COVID-19? It's still the same things. Over the past week, there have been several, we can talk a little bit about some of the vaccine trials and such, and some of the things you may have heard, but other therapeutics other than the vaccines, we're still looking at remdesivir and dexamethasone, and there are some others that are, in various trials right now around the country, but nothing that's overly promising right now at this point. The biggest thing will be the use of antibody therapy. These are antibodies that have already been produced by others and then harvested and then transmitted or infused to other people to try and defeat this virus. So theoretically it should work, but anytime you take serum from one person and spin it and so forth like that to get rid of a lot of the other antibodies and other things that we'll make reactions to, there can be some issues there. But we're hoping to see that that's going to be very helpful. We have some friends actually who have donated serum in different places of the U.S. in trials for this very purpose.
Dr. Owen, one more at the bottom of this about travel, air travel.
Should people who travel by air be quarantined before returning to a workplace, or is air travel safe assuming everyone is masked? Well, the last statement never happens. Never seen an airplane where everybody's masked. I'm not saying this never happened, obviously, but it's really hard to enforce. And a lot of the people keep the mask below their nose or lift it up above their mouth so that they can breathe better and so forth. But we do know that the airplane filters have helped significantly in decreasing the spread. But the air movement devices, fans and so forth, help to push it around. And obviously the close quarters and the coughing and all those types of things. It is recommended that, especially if you travel to hotspot areas or coming from hotspot areas, that be taken into consideration, that to quarantine those folks before returning to work.
Okay, not seeing any other questions. Dr. Owen, I'll let you get to the agenda.
All right. Each one of these questions has an answer, but it also has 4 or 5 different sub-answers to it where you can come up with scenarios where it wouldn't necessarily be the case. I'm happy to answer those individually. Next slide. All right. Alluded to it, I didn't allude to it. I told you last week that COVID-19, the flu, viruses A and B, colds, allergies, other types of viruses have a tremendous amount of overlap. And this is one of the reasons it's going to be so hard to know whether or not somebody's symptoms are benign, like allergies, or they truly have a viral illness. Could they have flu? Is it COVID-19? There's really almost no way to tell. And this is going to put a lot of burden on the patients, or the person who's ill, to fess up and own up to it, but also to the employers on how they're going to handle this. So look at the top line there, onset of COVID-19 versus influenza. So influenza is notorious for coming on suddenly. The analogy I always tell my patients every fall and winter is that you walk into the grocery store feeling fine, or probably Sam's Club, that's the one that takes you several hours to get out of. And you come out and you feel terrible. You've got a headache, runny nose, maybe a little runny nose, and a cough. But more importantly, you have a significant fever, over 101 usually. And it's very sudden onset. Whereas COVID tends to be a more insidious gradual onset for 2 to 7 days. Cold symptoms, some people, as you know, you wake up with a cold, you felt fine the night before, or the night before you felt a little unusual and the next day it's full blown. So it's more of a gradual onset. Allergies can be sudden onset. Sometimes they can even be drawn out. So muscle aches. Most viral types of things cause aches. So as you can see, it could happen in COVID-19, flu, or cold symptoms. So not very specific to tell you one way or the other. Difficulty breathing. Well, sure. Flu people, influenza people frequently have a pneumonia with it. And it can be pretty acute in onset. And COVID-19 folks frequently, if they start getting significant, they'll feel winded as well. Not very common to feel really short of breath if you have a cold, unless you have some kind of underlying emphysema or something of that nature. So chills, sure, can happen with any of them, except for allergies usually. Coughing, yes, with all of them. Diarrhea and vomiting, we all know that diarrhea is one of the 10 to 12 symptoms of COVID-19. Can certainly happen in cold symptoms if it is other types of viruses than the routine rhinovirus. So there are some adenoviruses can do it, some other things like that, but diarrhea is not a real common thing for cold and flu. It can happen in COVID-19. It's usually more common GI viruses or bacterial infections like staph and strep infections with things you've eaten and so forth. Fatigue and weakness, pretty non-specific symptom, can happen with flu or COVID-19. Fever. You can get fever. Some people get aches and chills and fever, low-grade temperature with cold, but usually a high spiking temperature with flu, more of an insidious onset of fever in COVID-19 occurs over a couple of days, but it can be high. I've had patients tell me that one just this week tell me that he thought he had the flu, went in, he had COVID-19. He said it was worse than any flu he ever had. He was one that didn't feel like you should ever wear a mask. Now he's telling everybody to wear a mask. And he lives in Destin, Florida, but he's up here half the time, and he sees us. So he's spreading the gospel down there. Headaches, very, very common in true influenza, very common. And it's usually pretty much acute in onset as well. Bad headache and temperature within hours. Loss of taste or smell. Well, I don't know about you. I might disagree with this particular thing. When I get a cold, and I mean, I can't smell or taste anything, that kind of thing. So, I mean, you're just so blocked up, and it affects your taste buds and so forth. But sneezing, not that common with flu and COVID-19, although can be, depends on the individual. Sore throat, definitely one of the signs of COVID-19, flu, can be with cold as well, with postnasal drip and stuffy nose. Sure, absolutely. So look at that. I mean, with all the most common symptoms, you can't rule out any of these things hardly. And so as a result, the problem is going to be, what in the heck do we do with these people who have had the common variety symptoms of mild viral illnesses, and now we've got it superimposed on COVID-19? Well, we're kind of stuck. We are forced to consider it being COVID-19, and in this particular situation. So what are we going to do? I mean, you have 25 people who are, out of several hundred who come in with, cold symptoms. We've got to send everybody home. Well, this is where I think that the type of testing, more so now it's important than at any other time during this pandemic, because we have all these other superimposed viruses, and it's going to be really hard to determine. So there's routine testing that you can do that's symptomatic. So if you want to do PCR testing, with nasopharyngeal or saliva testing, the optimal time is the third day of symptoms. So that means they're at home for 3 days, and then you get the thing back either that day of testing or the fourth day, and they've missed all 4 days of work already. And that's assuming they're negative. So that's why we're going to employ the point of care testing both at our clinics, and we'd like to be able to offer that as well to those of you on this webinar, and that we're having contracts with other employers and things of that nature. And so what we're doing and actually getting ready to implement, and I wanted to be able to share it with you today, but it's not ready for prime time, but our COVID task force has tasked them with last week putting this together, what's going to be our standard protocol with this type of process. And I think we're going to use this point of care test very specifically. When patients come in with symptoms, if they look bad or they've got a fever, we're sending them home. If they don't look bad and they don't have a significant fever, then we're going to point of care test them with a nasopharyngeal swab using the Roche Liat testing system. We've had to reprogram all of our Liat testing systems throughout our all of our clinics. In our 11 clinics, we have them in each place, and also in our satellites. We have, I think, 5 each in the each of the satellites as well too. So we can run these, and they are returned back positive or negative in about 15 minutes. They also have flu A and B with those point of care tests. So let's say somebody is positive. Well, you're going to send them home because you're going to say, oh, wow, we caught them early. And it's a great way of starting your contact tracing at the first day of symptoms. But let's say they're negative. Well, they have a cycle threshold on these particular tests of about 35, which is right at the level that we would want to show whether or not somebody's contagious or not. And so if these tests, this point of care test is negative, they should not be contagious. Doesn't mean they don't have the virus, but they're not contagious yet. And then we would recommend that you test them on sequential days for 3 to 4 days, because by then you should be able to document that they're either positive COVID or negative. And in all honesty, 95% of the time they're going to be negative. But that's what you want, because you want to be able to keep the people at work who otherwise aren't, looking toxic and sick and febrile and so forth. So that's how we're going to do it, because otherwise I think if we have to send everybody home for every cold and sniffle they have, we're going to be in trouble from a workforce in taking care of patients. And I would imagine that many of you would have the same issues. Next slide. Well, raise your hand if you're tired of seeing these slides going up. Here it goes again. I mean, we're up another 19%, 14-day change. We're going to be really, really testing the supply chain for testing capability for both PCR testing because of test tubes, swabs, and reagents, and where we get them from. And since the vast majority of people who are symptomatic are not going to have COVID-19, there's more of those now than any other time, we're going to put a lot of pressure on the testing supply chain. As a result, we saw what happened back in July. And in July, we overwhelmed the largest of the testing centers, and their turnaround times, the TATs we call them, stretched out from 2 to 3 days to as long as 10 to 14 days. Anything beyond probably 3 days really is worthless. It really doesn't help you much from a contact tracing standpoint. You've already spread it many times over throughout a workforce. And so we are seeing it without question that we are significantly increasing the number of tests. But remember, our percent of positives will likely not be as robust or as high because the denominator is going to have so many other tests for viruses that are not COVID. But pay attention mostly to the overall positive number of tests, not necessarily the percentage of tests that are positive. Hospitalizations are also on the rise. The deaths, as we mentioned, usually lag 2 to 4 weeks behind the increase in rate of number of positive tests, then followed by hospitalizations, then followed by death rate. Although deaths topped at 4,000 on 10/21 here in the state of North Carolina for the cumulative amount. Trying to remember what the exact number was. It seemed like it was 16,000 in the state of North Carolina in 1918. I have to go back and look at that again. But anyway, this virus compared to 100 years ago, probably not as deadly, but significantly more contagious. So it'll spread a lot more easily. And when that happens, then you have the risk of getting more hospitalizations and deaths because of just the vast numbers that get infected. So we really have to watch out for this. Not a lot else to say here. Oh, I know. I actually got asked by a patient today, why is the death rate not increasing? In other words, deaths compared to number of positives. And I think that's probably one of the better questions a patient has asked me recently. And it's for a couple of reasons. Number one, we have more testing capability now, so we can test people who are less symptomatic and so forth. And so the total number of tests, total number of positives, we're finding more people. But that doesn't mean the sickest of the sick hasn't really changed. So the percentage of death rate to positive tests will go down because we are actually increasing the total number of positive tests. We're testing as many as 1 million a day now, but that's only 3%, less than 3% of the population. That's an issue in itself. So that's one of the biggest reasons. Secondly, we are seeing more of that spread because we're indoors more and things of that nature. And then lastly, we're better at taking care of these people now. We don't, as soon as they get into respiratory trouble, we don't go slap a ventilator on them anymore. We are able to give them remdesivir in the hospital when needed. It's not widely available to give convalescent antibodies, serum antibodies. That's not widely available at this point. Dexamethasone is. And the very aggressive pulmonary toilet, we call it, by getting people to move this stuff out of their bronchial tubes rather than let it obstruct, positioning of the body face down so that we can, through gravity, be able to get this out more. And we've also relied on not putting patients on the ventilator as early as we used to because it tends to weaken their muscle systems because they stop working. We start doing all the work for them, and then they get tired, and it makes it difficult to get off the ventilators too. So those are the main reasons. Any questions so far?
No questions. And Dr. Owen, we got 5 minutes. I know you got a little bit more that you want to get through.
Go ahead.
And then I want to, at the end, just see if anybody else wants to jump in.
So these, again, are the treatments and drugs. Not much change from what we said before. The antibody trial put on hold due to a safety concern. Still have dexamethasone, remdesivir, the potential antibody cocktail. Nothing's really changed here in therapeutics of any great significance. Next slide.
And the one question that people ask is this widely available? The things we hear and see in the media, could the average person get those?
Yes. So remdesivir, first of all, dexamethasone is in every medical office and in every hospital like crazy. It's used very frequently. Remdesivir is available. If it's not immediately available and they think somebody's going to need it, they'll be asking the national pharmacies to send it to them for those particular patients. So it is available, and especially because they start using it after day 5 to 10, not necessarily immediately, so they have the ability and time to go find a source for it if they don't have it in stock at the time. Is that the last slide? I want to talk a little bit about the trials. The Moderna trial looks like it's going to complete its enrollment, if not this week, at the end of next week. 30,000 patients across the nation. That's really good to know. There have not been to date any types of reactions or adverse reactions, we call them. They were serious enough to have paused that trial. However, if you remember that first trial with AstraZeneca, that is part of the Oxford trial, they use a protein, the spike protein with a dead chimpanzee adenovirus, and they've now had a second patient have a severe illness and are pausing yet again. The J&J Johnson & Johnson trial that's known as Janssen, that's their research arm. They had a single significant adverse reaction. We've not seen much in more detail of that. We ourselves will, as soon as we have more information on it and are able to, we'll be actually initiating that particular trial here at Tryon. But obviously be very cognizant about the risk benefit and so forth like that. So we're going to do a lot of digging to find out exactly what occurred and what we're allowed to know and can get hold of.
I usually give Dr. Owen a minute to wrap up, but one of the things that we typically get asked is just the practical side of who do I get tested? Who do I not get tested? What if they're symptomatic? What if they're asymptomatic? Dr. Owen hit that in a little bit of detail, but let me just ask the group, is that something you would like him to comment on as we wrap up here? Are you good with sort of the practical side of what you're doing to keep your business running? So I'll look in the chat here for a minute. We got about 2 minutes left, but let's see if anybody wants to jump in.
Actually, Patrick, I would say it's actually pretty easy to state it. If somebody's asymptomatic and they've been exposed, the optimal time to test them, if we're going to test them, is at least 5 days. Some people say 4, but generally it's assumed 5 to 7 days after the contact when the patient may have been exposed. That's the best time. Now, it's not necessarily the only time that they might become positive. It might become positive at day 10. And 10% of the people are after day 10 up to as long as day 14 that their first symptom starts. However, or when they become positive, the symptomatic patients are the ones that are a little bit more straightforward. Somebody's symptomatic, if you're going to send them home and you're going to do a routine PCR test and not a point of care testing, then we'd recommend that you test them starting at day 3. We can do couriered same day turnaround to try and decrease the time out of the office so that we can get it back a day earlier, but we should be able to get all the samples back the following day. And so it's a 1-day turnaround, but that's 4 days out of the office potentially if their first day of symptoms was when they walked in that particular time. So we tested day 3 primarily for symptomatic patients. If, however, and this is what I'd really recommend, if, however, we have situations where we've got people coming in to the office, employees, staff, physicians, workers, et cetera, then point of care testing is probably the way to go to be able to keep those people in place. but you're going to probably have to test them sequential days of 3 to 4 days in a row. If they become positive, you send them home. If they're negative, you can keep them in place because they probably didn't have coronavirus. And they weren't contagious, or that test would have been positive.
All right, Dr. Owen, we'll give you just a brief pause here and looking in the chat. I don't see any questions or comments, so we'll let you wrap up quickly. We're about a minute over, so we'll try and do this and we'll let folks get on with their day.
It's ramping up. It's the second wave. We hope it's not going to be as bad as it looks like it might be. Estimates are that it's going to linger and probably peak somewhere in mid to late December, which is an ouch. We would like for it to peak earlier and be done with. And hopefully we'll have this vaccine ready to go. There are some speculations through Moderna that Moderna may have as many as 20 million doses ready before the end of the year. We've got to develop herd immunity one way or the other. Either we've got to catch it or we've got to vaccinate for it. One of the two is going to happen.
All right.
Everybody has a good weekend. Stay safe.
Great.
Stay safe. Be more vigilant than you've ever been before.
Great advice here as we wrap up. And so seeing no other questions, we thank you for the extra 2 minutes. We've gone over a little bit. Hopefully this was helpful. And as a reminder, we're going to keep doing this until, things start to subside. So tell us if there's something specifically you want us to address, but we're going to keep bringing this timely info to you as we go along here. So with that,
yeah, that would be great. I appreciate you saying that, Patrick. Please send your questions early. We'd love to address some things, situations you get yourself into and you want some help. We're happy to jump in and help.
All right. With that, we will bid you a great afternoon and evening. Thank you for joining us, everybody.